Good morning, everybody. Our warmest welcome to Milano and to our CAT lab for the meeting. First of all, let me introduce my colleagues and friends. They did a great job to made everything ready for you. On my right, Mohamed Les from Palestine, Lucien Pazza from Brazil, and on my back, the nurses, Lina, Claudio, the technician David, and also Federica, the anesthesiologist. So we have here a nice case of a coarctation that Mohamed is going to introduce you. Next slide, please.
Thank you very much. Next. This is a male patient, 8 years old, body weight 24 kilogram. He is coming with the diagnosis in infancy with a small ASD-BFO. At the last follow-up check diagnosis of aortic coarctation, he is asymptomatic with normal growth. Physical examination, he had ejection systolic murmur on the left upper sternal border with weak femoral pulses. ECG, sinus rhythm, normal AV conduction, left ventricular hypertrophy. Next. Here we can see the echocardiography, small interatrial communication with left to right shunt. Globular shape, left ventricle with preserved function. Tricuspid aortic valve. Left aortic arch with the Doppler flow acceleration in the isthmal region was gradient 45 with diastolic runoff. Next. Here we can see the CT angiogram with the measurement of ascending aorta 20, isthmus 10 millimeter, coarctation site 5 millimeter, descending aorta 15. Thank you very much.
Okay. So we check the pressure as first step. We approach percutaneously the femoral artery with a 6 and then a 9 French sheath, and we check all the pressures. May we have the pressure, please? Okay, as you can see, we found a gradient, a peak gradient of around 24, 25 millimeters of mercury. We did a couple of angios that we are going to show you. Angios, please. So the first, in the ascending aorta, we see the neck vessels are normal. The ascending aorta is dilated. We confirm the diameter of around 20-21 millimeters. The transverse aortic arch is around 10.5. Next. You see the isthmus was measured around 9.7 millimeters here, with a narrowing segment, a very discrete coarctation, distal to the subclavian artery. The diameter of the coarctation was measured at the angio around 3.9, 4.2 millimeters. And the distal dilated part of the descending aorta is around 15 millimeters of mercury. Next. Millimeters, sorry. Next. Lateral, okay, perfect. This is a lateral view. Okay, they just confirm all the information. Next. AP view. Okay.
So, Massimo.
Yeah.
Yeah, it's John. So right now, you have a 7-8-year-old girl, 24-year-old kilogram. What goes through your mind in treatment? What are your options? Balloon angioplasty, bare metal stent therapy, covered stent therapy? What are you thinking?
So we are thinking about to implant a stent, a covered stent. And we decided to do a covered stent for many reasons. First of all, the diameter of the isthmus. We don't like to dilate it with just a balloon. Since a long time now, this kind of coarctation, because in our experience, the incidence of wall injuries are all of them related to the balloon angioplasty of bare metal stents. We were wondering about the possibility to implant a bare metal stent in this child because of the weight, but actually, because we are the possibility to use the new advanced stent that can be introduced through a small long sheath, our option at the moment is to put a advanced stent, cover stent, pre-mount cover stent. I don't know what you think about that. What's your suggestion?
Let's see. Those Elkanen, here. We had Elkanen Brakame here, and so he has, the probably world's largest experience with the Advent of 12. Yeah, Elkanen, your comment about what you do in this patient. Microphone on, please.
Yeah, I think I put in a V12, large diameter on a 12 millimeter balloon, 41 millimeter length. Take it up just under where the subclavian is and dilate it up that way. And then I would consider post-dilating depending on how much movement there was behind the stent.
Yeah. Okay. Yes, I agree. I show you the stent if you want. Please zoom here. You know this stent probably is a stainless steel stent with an open cells design with some EPTFE that is on the interior-exterior aspects that cover completely, encapsulating the stent actually. The length we choose is 41 millimeters. We check the space that we have. Actually, we believe that 41 is the right length because dilated up to 8 atmospheres in order to reach 12 millimeter diameter. We will get a length of about 35, 36 millimeters. That is good enough also because if you are to redilate the stent immediately or maybe in the next future in order to allow some growth of the patient, we have the possibility. The open cells design gives us the chance to adapt the stent to the anatomy because it's a very soft one. So if you give us the chance, we will go ahead to move on. Okay?
So Massimo, you have a 9 French sheath in, is that correct?
Yeah. 9 French sheath, yes. Actually, the stent can also fit into an 8 French sheath, but in some cases we added some difficulties to pull out the balloon once inflated. So I prefer to use the 9 French sheath. The suggestion 8 or 9 French sheath.
Yeah, that also allows you the ability to do your angiogram and precise placement if you don't have a second arterial catheter.
Yes, exactly.
Massimo, one question. Where did you place the guide wire in this case?
I placed the guide wire in the subclavian artery because I like to have the system completely straight for. I show you Flora, yeah? Okay. Maybe Flora, please. Okay. So maybe now you are seeing the guide wires and extra strip guide wire 035. In the left subclavian artery. The 9 French.
Massimo, before. Yeah, no, keep going. Before we know the results of this, we're going to ask the audience to hold their hands up. How many of you would perform balloon angioplasty at the start? Raise your hand.
May I beg your pardon? I didn't get.
How many of those of you would use a bare metal stent?
Yeah.
Raise your hand. And how many of you, some more bare metal. And how many of you would use a covered stent?
How many of our patients?
The far majority of the covered stent. They agree with you.
The majority, yeah. Okay, ragazzi. So I don't cover the stent because to pass the valve because it is not necessary. So I'm advancing the stent. Okay. Hold on the guide wire, please. So, ready with an engine? I think. So, we are a little bit high, I think. Okay. And uncover a little bit the stand here. Okay. Just a test. Just a test here. Okay. Okay, ready? Ready to do an engine? Okay. Go. So we are a little bit higher, so it's better to go down a little bit here.
Massimo, as you're doing this, I was just wondering if you would do if you had done your first injection so you could clearly see the left subclavian since that's your target.
Yes, I'm pretty sure that we are here in the right spot. Next entry here, please. Okay. So, do an entry here, maybe better. Yeah? Just, okay? Do an entry here? Yes. Okay. Because show the entry, please. Show the entry, please. Yes, because the landmark is the inferior part of the rib. Okay. I think. Do an entry here, okay? Go.
So, Massimo, you and Elkanen agreed on the 41 millimeter. What would be the next shortest stent for the Advena 12?
The shortest 29, I think.
As Carlos Pedro knows, I always think sometimes they look way too long for the lesion. 2/3 of it are below the lesion, which is not necessary. So I guess it's just the disadvantage of maybe the discrepancies in the lengths available.
Yes, actually, once dilated, the stent will be around 35. Around 35. Okay. Fai un angio qua per favore.
Yes, Elkin. Okay. Comment.
Two things. I think that he shouldn't come down any lower than he is. He's just at the bottom of the transverse arch. The stent's going to get shorter, and I never use the left subclavian unless there's a real reason for doing that, because the problem here is that as he expands the balloon, even though the left subclavian is big, it may push him down, and then the stent will be too long. Too much of it will hang below. So, I mean, either you can still slip the stent out and put it in the right subclavian, and then I think it'll give you more purchase to put the stent a little bit higher, and it won't milk down, and then it'll look much better. I think going for the left subclavian here makes it much more difficult to do this case. So if you are staying where you are, then as the stent starts to push down, push it up as you will come down below.
Okay, it's a good suggestion. Actually, I have the habit to leave because it gives me more indication about the exit position of the stent. I don't give me any curve on the stent when I inflate in. So I think this is the right spot. Okay. Okay, enter here. A second. Okay. Go. Okay, it's not clear, so maybe what I'm going to do is just that, because I think this is the position, just to do an angel here. Okay? Go. Okay. This is the right spot, okay. Ready? Here. Another angel here, okay? Vai. Quanto stiamo iniettando? Okay, I think this is the right place where to deliver the stent. What do you think?
Looks too low.
Here. I think this is the right.
Elkonen? Elkonen? Coming? I know.
Okay. Okay. Andrew here. Facciamo 25, 18. Ok.
Massimo?
Yeah.
Is Mario.
Yeah.
I think the stent is rather long for the discrete lesion, so probably a shorter stent would have been okay as well. But I think taking into account the percentage of shortening, I think this long stent is going to be all right as well. However, I will try to put the stent a bit higher up. I mean, I'm afraid of the stent can slip when inflating a balloon, so I will just partially jail the subclavian actually, or at the end of the subclavian.
So what?
Yeah, you agree, Massimo?
Yes, yeah, you know that.
You have a good reference point there, which is the endotracheal tube. I think the stent will be placed rather there.
I think this is the position of the stent.
Here Dietmar from Gießen, Germany. I have an additional comment to the stent, the shorter one or longer one. But it is most important that you have to be precisely delineation of the aortic arch. If it is a little bit too high, you can have the risk for infolding over time of this kind of stent. And we have seen this, and it was a real, let me say, high urgency case 2 weeks later.
Yeah, that's right. However, based upon the both the angiogram and the CT scan we see, the isthmus is rather straight. So I think my wish, Massimo, is to expand the stent just at the end of the subclavian. Elkanan, any other comments before the end of the day?
Yeah, I mean, I'm sorry about this. I would take the stent out, put the wire in the right subclavian artery, shoot an angio, and then make a decision.
So Massimo, I don't know if you heard the end of that.
Yeah.
Yeah, Elkonen had recommended, so you have a better idea of the precise placement, the transverse arches, to probably rewire to the right subclavian artery, so you're not bound by the left subclavian artery there, and then probably place the same stent and decide whether this is too long or not.
So you suggested to change the position now of the guide wire.
Elkonen strongly believes that it's over in the right subclavian. We stopped using the left subclavian to deploy our stents for the reason Elkonen talked about, is that sometimes the balloon, depending on how big the subclavian is, will push you down and it will make you go more distal. So we typically use the right subclavian, and then in complex arch we put it in the ascending aorta.
Okay, we can do that if you want, if you have enough time.
They usually use the ascending right aorta or
Allora, facciamo un angio qua, ragazzi. Vai. I think this is the position. I think this is the
So
position.
what we're going to do, Massimo, while you change, Mark Giveling is ready, and we'll go very quickly. Are you going to change to the right subclavian, or are you going to stay where you are?
If you give me 10 minutes, I will change the guidewire. I will do that. Okay.
Why don't you go ahead and do that? And they're ready in Belgium. We're going to return, and then we'll come right back to you.
Okay. Okay.
Thank you.